everybody, I'm Marcia Pafak and I'm a GP in North East Lincolnshire, and I'm one of the clinical leads for the Children's Asthma team for Humber and North Yorkshire. We've worked with the Adult Respiratory Network to bring you the all-age asthma formulary, which I'm sure you're familiar with now, and I'm here today to talk to you about clinical coding in asthma. So why is accurate coding important in asthma? Well, firstly, it gives people like myself and the Adult Respiratory Network lots of information about our population across Humber and North Yorkshire. So we can look at the different places, how many asthmatic children and adults are there. We can look at how many admissions to hospital with exacerbations the population has. We can align that with things like poverty to see whether that's having an impact, and we can look at prescribing across our populations as well. So it just gives us lots of rich information which helps to determine what we need to prioritise on and where we need to go next in terms of our work plan. Audit, really important of course in GP practices and trusts. This is what allows us to assess the quality of care that we're delivering, both in terms of what we're prescribing and how often we're reviewing, etc. We can't audit properly if we don't have our patients read coded properly. Recall, essential for our patients to have recalls after exacerbations, for instance. Often there will have been medication changes that need to be reviewed to determine whether the patient's improving, both in the shorter and longer term. We have annual reviews for our asthmatic patients, which are important for us to check in. We can then check their personalised asthma action plan, their inhaler technique. We can make sure they're not overusing their salbutamol or reliever inhalers, and we can check that they're not underusing their preventers and that they're compliant with that medication. Also, it gives us an opportunity to check in terms of social factors like smoking, occupational factors, mould, damp, air pollution, etc. And poverty as well, again. So we can't recall them if we don't know who they are. Other administrative issues, particularly I think within GP practices, around recall and flu vaccines, etc. as well. So lots of important reasons there why this population is accurately coded. So in a patient who has asthma or suspected asthma, the code firstly needs to be specific. If we are pulling in, when we search on that code, lots of other patients who don't actually have asthma, but maybe have COPD or have chronic lung disease of prematurity, for instance, then the data is going to be less meaningful, and also any audits are going to be an absolute nightmare because we're going to be having to go through each set of notes and exclude lots of patients. So it's really important that we have a specific code. It can't be easily confused with other conditions. So we would want to avoid symptom codes. We would want to avoid codes like wheeze, or we would want to avoid codes like breathlessness, because they can apply to so many different conditions. The second thing is that we want codes to be accurate. So if we put a diagnosis code of asthma on somebody's record when they don't have asthma, particularly with a child, and particularly if that code comes from secondary care, it will then be recorded into primary care notes potentially by administrative staff, and it then becomes fact in terms of the record. So that child then will be called in for asthma reviews. They will potentially be left on treatments that they may not have been left on otherwise. They could even have more time off school as a result. And I've had patients who haven't been able to go into the armed forces because of asthma codes that have been in their medical records since they were a child, even though the individual that I speak to swears that they've never actually had asthma. So yeah, far-reaching implications of inaccurate coding. And of course, the other way, if we don't code someone with asthma when they have asthma, is that they won't get all those rich recalls and management. We won't be checking their prescriptions, we won't be checking their compliance, their inhaler techniques, etc., etc. So accurate coding is very important. So the core asthma codes that we would like you to use, we've kept it extremely simple, and we've very much focused on diagnosis. So the codes are asthma, suspected asthma, viral wheeze, asthma resolved, and exacerbation of asthma. Now, we work on different clinical systems, and certainly we've got practices that are on EMIS or System 1, and we've of course got the hospital trusts. My understanding is that all hospital trusts have used SNOMED CT since 2018, and that the EMIS and System 1 codes are also rooted in SNOMED. So for instance, I've listed the SNOMED codes on the screen here, and the SNOMED code 195967001 at the top is the asthma code. And if I were to type that into my System 1 search box, the read code search box, that number there, the SNOMED code number, it would come up with H33, which is the asthma code, which we would want to be used in asthma. And similarly, if somebody on EMIS were to type that code into their EMIS search box, it would come up with the equivalent EMIS code, which is the code that should be used in asthma on EMIS. So yeah, we're all essentially using the same codes, but it's just important that these very clear codes, and I'll explain a bit more in the next couple of slides around the context of when we would want you to use them. So preschool children under 5, these children often won't have a diagnosis of asthma yet. Some will, but it's actually quite unusual. So these patients fall into two main groups. Firstly, we have the viral wheezers, and these viral wheezers tend to have very intermittent symptoms. So they'll get a virus, it might cause a sore throat or a runny nose, and they will wheeze with it. But in between these episodes, which might be a week or two long, they will be clear of symptoms. So often these children are given salbutamol to relieve those symptoms, and occasionally they're quite severe and they are given some prednisolone. But the key point about them is that they are well between episodes. The second group of children are the suspected asthma children, and these children are much more chronic and frequent symptoms. So they will tend to get worse during exacerbations, like any asthmatic child would, but they will also have interval symptoms as well. And these symptoms may be things like the nocturnal cough and wheeze, breathlessness on exertion or when exercising. They're often treated with preventative medications such as Clenil or Montelukast, and they often have past medical history or family history of atopy. So that's the kind of picture that you tend to get with those children. Now, children with either of these codes, particularly if having ongoing treatment, would benefit from regular review, and certainly would need to be reviewed at age 5 to determine if they needed to have diagnostic tests. And those diagnostic tests would be with a view to making an asthma diagnosis at age 5. Children with the code should certainly have diagnostic tests if they are on ongoing treatment with either Clenil or Montelukast or salbutamol. And I would say that probably to be safe, if they've required that treatment for symptoms in the last year, it would be sensible to consider diagnostic tests. If they've not required any treatment in the last year, not had any symptoms in the last year, then it's most likely unnecessary. But obviously they could be reviewed if they had further symptoms, so you could certainly safety net those children and their parents to come back if symptoms occur. In children aged over 5 and adults, we still use the suspected asthma code, but it's used slightly differently. So whereas with under 5, you may have that code on for several years, whilst you wait for them to become old enough to be able to participate in the diagnostic testing, with children aged over 5 or adults, we would expect that the suspected asthma code would be a much shorter term code, and that would be used in new presentations or whilst awaiting diagnostic testing, or if the diagnostic tests are unclear. If you, in the rare circumstances where you, for instance, in an adult with a learning disability or a child that was really unable to do a diagnostic test, and you may need to do a trial of treatment and then a review, it would be reasonable to leave the suspected asthma read code on there in the meantime. A really good quality improvement plan for practices is to search for children over 5 with the suspected asthma code, or even the viral wheeze code actually, and to see whether they've been followed up appropriately. Asthma code, that should be used after face-to-face assessment of symptoms or signs of asthma, along with review of relevant history in the child or adult or family, and diagnostic testing. Most children can perform testing under the right circumstances, but in the rare case of a child being unable to do that, then a treatment trial with a thorough face-to-face review afterwards can also aid diagnosis. The key point there is that these children have to be followed up. If they're having a trial of treatment, that has to be followed up. Is there a role for a severe asthma code? Possibly, but it's unlikely to be useful. I understand from adult colleagues that if we are searching for adults with severe asthma, then that search will be done on medications rather than diagnosis. I would certainly say as a primary care doctor that I would only enter that code onto the record if it had been severe asthma had been diagnosed by secondary or tertiary care, or if they were under severe asthma service, for instance. Exacerbations, so of course many issues can cause an exacerbation of asthma. Allergies, viral upper respiratory tract infections, etc. But it's important to code the exacerbation as well as the precipitating factor. So if I have a child with an upper respiratory tract infection who also has an exacerbation of asthma, then I need to code the exacerbation of asthma, because simply coding them as viral upper respiratory tract infection will not necessarily capture that exacerbation. The problem with that is I might not then realise that they've had 3 exacerbations that year and really should be referred on to secondary care or really should have their treatment titrated. It's easy to miss those things if we're not read coding properly. So I think, the takeaway from that is that certainly code the viral upper respiratory tract infection or the tonsillitis or the hay fever, but please code the exacerbation of asthma as well. And that's exacerbations that require hospital admission or accident and emergency attendance, but it's also the ones that occur in primary care. So that's everything from my presentation. As I say, I've deliberately kept it quite short and simple, and I hope it's been helpful.